We're going to have 6 cases in a row, and I think this is, if you really commit yourself on paper, I think it's most effective. And for each of these, I want you, before I say what it is, to put down N, I, or O. N means neoplasm, I means infection, and O means osteoporotic insufficiency fracture. And you may say, well, this is unfair. You know, I would ask for history. The history I'll give you is this is an elderly woman with a history of breast cancer who's in a nursing home and has chronic urosepsis and is very osteoporotic, and she fell out of bed and her spine hurts her terribly, and you know, the mobile x-ray company took this horrible dark thoracic spine film that shows a new compression fracture in mid-thoracic spine that was not there a month ago when a similar incident occurred. So you have a history that's, you know, quite detailed and not terribly useful. So that was just to create a little time for you to think. And now put down N, I, or O. All right, well, you're all committed on paper now, and I think the important features of this case are as follows. Certainly, there's more than one lesion, and if you find more than one lesion, you've got to think about metastatic disease. There's another lesion up here. With infection, it tends to be mostly centered around that one disc that has the discitis, or maybe 2 vertebrae, 1 disc. When you give the gadolinium, there's some epidural enhancement, but it pretty much matches the tumor in the epidural space. You don't have the anterior longitudinal ligament enhancing all the way up to the skull base. It's very localized. The posterior elements, again, very hard to see the posterior elements sometimes on the sagittal, but here you see this is the lamina. This lamina is normal, this lamina is normal, that lamina has tumor in it. So you may not actually get the axials because, say, the patient desaturates or is claustrophobic. Sometimes you don't get all the images you want, but you have enough here to say overwhelmingly likely this is tumor and overwhelmingly likely neoplastic. This was a lung met. Okay, so the features, several lesions, not a lot of ligamentous enhancement, posterior element involvement. So those are the things that you should bear in mind looking at case number 2. And if you want a history, this is actually a twin of patient number 1. So has identical medical problems and history. And you can assume that for the remainder of the cases. So I'll just, you know, send the little arrows out for you to look at some of the key features. And I want you, just a few more seconds, to put N, I, or O down. You know, when I used to sit at these sessions, I just kind of sit back there and say, oh yeah, I would have said that. But sometimes that wasn't the case. So anyway, here are the features. Of course, you have a compression fracture, and 100% of the marrow of the compression has converted from fatty marrow to abnormal. And that's unusual in osteoporosis. Usually with osteoporosis, there's a little normal marrow left somewhere. There aren't, I mean, there's some compression fractures, but there's no other vertebra that really looks this bad. With gadolinium, there's tremendous enhancement of the anterior longitudinal ligament quite far away from the actual lesion, not to mention all of this epidural enhancement here. So there's something clearly intensely inflammatory here. And there's nothing more inflammatory than, say, a staph or E. coli infection, and this actually happens to be an osteomyelitis from urosepsis, okay, infection. And the disc is not particularly enhancing, a little bit, but it's really the vertebra. It's more in the osteomyelitis phase than the discitis. Now let's move to patient number 3. And this one, I just give you a little moment to look at the features here. Once again, every pixel of marrow has converted to abnormal, so this is unlikely to be osteoporosis. What about the posterior elements? And remember how I said you've got to look at this posterior elements on the sagittal because you might not always have the right axial and make the most of your film. So there is a lamina that's expanded, and here you see beautifully on the axial tremendous expansion of these lamina. This is sort of the Michelin man vertebra. It's been all blown out. Yet the cortex is still there, and there's not that many types of things that will blow out a vertebra like this. Infection, unlikely. Infection would be very quick. This has been going on for a long time. I can tell you there wasn't a lot of infectious type enhancement here. The anterior longitudinal ligament looks pristine. Not osteoporosis because all the marrow is affected. So this is a tumor. It's a neoplasm. And in fact, you could even go out on a limb and say it might be a plasmacytoma because of its expansile appearance, or renal can do this too. But it's certainly neoplastic, and it was a plasmacytoma. Here's number 4. And again, same history. This patient, here's a plain film. It actually turns out it's a myelogram. And this was, but considered a plain film, you have this solitary compression fracture. But is that compression fracture of benign osteoporotic origin, or is it due to a pathologic process such as a tumor? You look at the T1 weighted MR, that's really all you need. Tricky case, because you might say, here's another lesion, but that could be a Schmorl's node. I don't think you can put too much confidence into that one. But look how this thing retropulses back. It has this almost sort of pregnant-looking portion that sticks out into the epidural space and compresses things. There's not a single marrow pixel left of normal fat. Osteoporosis doesn't bulge backward that way. Not a lot of soft tissue changes. This is a neoplasm. Next case. Looks initially just like the last one until you appreciate a couple of facts. And that is that this area right here is almost the same in length as this area right here. This is a wedge shape. And on the MR, all of the marrow fat seems intact, which excludes neoplasm. Certainly, there's nothing to go along with infection in terms of the paraspinous tissues. And this is a typical traumatic osteoporotic fracture that's actually healed up nicely. Okay? So I hope that's what you put, and put an O there. Now this is a slightly different companion case, but it's made to illustrate a point, and the history here is not an elderly patient. Think about what the history might be here for a moment. Here you see on T1 areas of marrow abnormality. There are essentially mirror image in these two vertebrae around the disc. They get very bright. This is a GRE T2 type image. And most of the marrow is fine. And the history here is actually, this is somebody who was fixing a TV aerial and stepped back to admire it on their roof, and they were in midair and went 20 feet into their driveway, had a jackknifing type injury. So really this is bad trauma, about as bad trauma as you can get without a burst vertebral fracture. Yet the trauma has not converted 100% of the marrow to dark. And it's very unusual that that happens. So if you see something like this, you can be pretty confident it's traumatic, and to call this a tumor with this type of mirror image appearance would make no sense. Infection similarly. So this is trauma in a non-osteoporotic patient. So here are some cases that I've found difficult in my own career, and I thought I'd share them with you. Is this infection, or is it C1-2 instability? And here you see all this fluid in front of the odontoid. Hard to know what you've got here. You see all of this degenerative disease. We actually put a needle into this and it was not infected. This turns out to be rheumatoid disease, but boy, I wouldn't exclude infection that lightly. Tricky case because of all of the inflammatory change. And again, if you don't know on an exam or in real life, consider putting a needle in. You know, we're not histologists, we're not microbiologists. Another tricky case, which I call aggressive degenerative disease. Here you have a scoliotic curvature. The disc has probably lysed. You get this very aggressive, infected-looking appearance, yet there's not a whole lot of enhancement here, just a little bit. If I was uncomfortable and the patient had a white count, a fever, I'd put a needle in there. We watched this. It all got better. It was just degenerative disease. So not every case is easy. Here's a case. It doesn't look that easy. You see a couple of vertebrae involved. You think, could this all be cancer, multiple metastases? But if you look at these vertebrae more closely, you see there's a little preserved marrow, kind of a little posterior flag of normal marrow in each compressed vertebra. And this is somebody who has a very low calcium score, very osteoporotic. And in these patients, you get multiple vertebral fractures. They're all benign in the sense they're not tumor. And there's this little area that signals that it's probably a compression fracture. Sometimes on T2 you can even see the fracture plane and the edema. The fracture plane will enhance. So another tricky case. But if you don't know, rather than struggling, consider biopsy. And a couple of points about biopsy. This is around T11, T12. There was a concern about going in and getting a pneumothorax. So what we did is we injected 50 cc's of saline into the extrapleural fat, and we created a window so we could get in without having a pneumothorax. You always want to go for an area that looks abnormal, where you don't want to go here where there's normal trabecula. You want to go into the more sclerotic, lytic area to get your diagnosis. And you can go with a needle, you can go extrapedicular, transpedicular. The needles, it's nice to go coaxial with a little 22, a wire, then a bigger needle, the way we do with nephrostomies or something. And then these bigger needles sometimes have little drills on them, and you can get out big pieces of bone. Once you're in with a big needle, you get lots of samples. You know, doing these with MR, you have to be very careful. I like to do them under CT, but carefully matching the numbers so you know you're going to the right vertebral body when you're doing them under CT. For instance, here is one. This was somebody who had this solitary lesion, and we went in, and sometimes they want cores. We went in transpedicular. I used a cutting needle, measured carefully. If I'd shot the cutting needle here, I might have gotten a blood gas out of the aorta. But pulled back, got some nice cores with this type of device. And it turned out to be breast cancer. They were able to get estrogen receptors, figure it all out, and they couldn't find the cancer, the primary, on a mammogram. But this was metastatic breast. So obviously you make friends with your referring clinicians if you do those procedures. Not all the mets go to the vertebra. This is a germinoma where literally the metastases have exfoliated off to the cerebellum and down to the lumbar region. Now here's what was done incorrectly on this imaging sequence. You see this area down here around S1. Is that tumor or is that just fat? Well, you don't know. You do a fat saturation. It was still bright. It turned out to be tumor. So you always want to use fat saturation in accompaniment with gadolinium when you're looking at this kind of disease to exclude those sorts of problems. And the dropped metastasis. Now, with gadolinium, you have to be careful not to call normal vessels around the conus dropped metastases. This is normal vessels, and particularly if you use triple gadolinium, you'll see them. And this are actual little nodules of breast cancer that you can see kind of invading into the tissue of the spinal cord itself. So don't mistake little peel vessels for tumor. And the other thing, if you're not sure, wait 20 minutes, re-image. The peel vessels will wash out because all the gadolinium is intravascular. It goes into the urine, and the metastases will still be there. So again, another clue is that the PO vessels are usually at 12 o'clock, 6 o'clock. The metastases are larger and more random in location. Well, finally, direct invasion. Here we have a renal lymphoma, and most of us would follow lymphoma with CT. That makes perfect sense. In this case, though, the patient had a little bit of back pain, abdominal pain. It was shooting around to their flanks. There was talk about doing a celiac axis block to make the back pain better, and I don't know if many of us would have called this little abnormality here. Of course, there is asymmetry to the psoas. I've made it large here. So what is really the problem? The real problem is lymphoma has infiltrated into the spinal canal. Very hard to see on CT, and even though we like to follow lymphoma serially on CT, if there's any back pain, get an MR, because it's so easy to get infiltration like this that you miss. And there you see the infiltration obvious on the MR. Now, the next few categories you're less likely to see on exams, but it's important to know a little bit about them. Spinal AVMs. I'm sure if you see one on the boards, it means you've passed. If you just consider them like tumors, abnormal tissue, either they're in the spinal cord, intramedullary, in which case they're congenital, you were born with them, they're dangerous because they bleed, like a brain AVM, they're in young people, or they're outside the cord in the dura, which is, or PIA, which is usually a spinal dural fistula. Those are older patients, and they're acquired. And I'll show you an example of each. Here are signal voids in the cord. There's the angiogram off the vertebral. This is a spinal AVM. The patient was born with it. It's dangerous because it'll get venous hypertension and it will bleed. If it bleeds, it's a catastrophe because the entire spinal cord diameter is injured. There's very little plasticity to the spinal cord. It's arranged linearly, not radially. It's hard to teach a new area of the spinal cord to take over the functions of that level. So this is what you want to avoid with the intramedullary AVM. Now, let's say you see lots of dilated vessels in the subarachnoid space, as you see here. And in that quiz case earlier, I showed you a patient that had these along with conus edema. That's a spinal dural fistula. And that's a different thing. This is the quiz case from earlier, and this patient had developed venous hypertension of the cord so that these veins, because they get arterial pressure, can't properly drain the fluid, and you end up with conus edema. And here you have a little fistula. It's like a dural fistula in the brain. You get an artery that feeds right into a vein. There's no capillary bed intervening. You weren't born with it. Usually it's acquired. So you have the artery on this angiogram running right into the vein. There's this little hairpin where it highly pressurizes all of the veins of the cord becomes edematous, and the catastrophe with that is if you biopsy the cord, you get all this bleeding. It's not a tumor, and it's something you just want to exclude before a cord biopsy. Congenital problems, this was a quiz case, and I'm sure you struggled with this a bit, but just imagine this was in the cerebellopontine angle. You would say, well, it's a CSF intensity lesion, it's extradural, or it's extra-axial or extramedullary, take your pick, and it doesn't follow CSF on all images. You could do a diffusion imaging to make sure that it's not, what, an epidermoid. This turns out to be an arachnoid cyst. So the differential of this lesion right around the conus is just what it would be in the CP angle for something that's non-enhancing extra-axial. It would be epidermoid versus arachnoid cyst. You would want to elicit, was there a spinal epidural anesthetic? Was there an LP, which might have created an epidermoid? So there you have, just think about it as the brain. Scoliosis, you see lots of scoliosis films. If you see abnormal vertebra neurofibromas, then it's congenital. If there's no abnormality that you can identify, then we call it idiopathic. And I'm sure you know this list of things that can cause a scoliosis, and they were reviewed on an earlier date. Here's an example of somebody who had scoliosis films that just showed the curvature, and it wasn't until they had the MR that they saw that it was a diastematomyelia. So scoliosis patients deserve one MR before surgery, because if you had done surgery on this patient, the little bony spur that you see here on the CT would not have been noticed. They would have stretched the spinal cord with the Harrington rods and jacks and whatever, and they would have torn the cord and caused paralysis of the patient. So the diastematomyelia. Chiari's, again the Chiari one, you should know the low cerebellar tonsils and the syrinx. A few comments about syrinx. If it's in the center of the cord like this, it's hydromyelia, dilatation of the central canal, and that you get with Chiari. If you have trauma, actually these can't both be the central canal, so this you would call syringomyelia. This is post-traumatic syringomyelia. Now, because we can't always tell the origin, there's this complicated term that covers both, but syrinx is probably fine. Chiari 2s, you probably know from your obstetrical lectures this week, and of course that has the changes in the brain as well as this spinal abnormality. And I'll just go quickly through the terminology. You all know about how the spinal cord folds around backward. This is mostly for your reference. If things don't close, you have spina bifida of different types. And I'll just show you some of the terms of the placode, which is this part here. If you have sticking posteriorly just the neural tissues, it's a myelocele. If you have CSF and the neural tissue, it's a myelomeningocele. So really the names, which are tongue twisters, can be easily derived from what is sticking posterior to the elements here. So this is a myelomeningocele because you have both CSF and neural tissue going back. Now all of a sudden, what if there's fat, as in these spinal lipomas? So here you have the intradural lipoma, everything's closed. Here you have neural tissue, so it's lipo for the fat and myelo for the neural tissue. And of course here's CSF a little bit coming out. So this is the real tongue twister, a lipomyelomeningocele. So just think about what's back there and you can pretty much derive the name. This is a spinal lipoma, for instance, one of the more straightforward. Here are lipomyeloceles going from small to big. Finally, we'll discuss trauma. Usually we do plain films in the ER, then we do CTs. Sometimes MR is helpful. Most of the trauma to the cord is actually degenerative. It's from chronic degenerative disc disease, from atlantoaxial instability, but we really wouldn't think of this as a trauma case, even though there's a little post-traumatic syrinx developing. But just bear in mind, most of the trauma is from the vertebra. Spinal cord trauma in accidents, there are all sorts of grades that you can study. There was an entity called SAWORA, or spinal cord injury without radiographic abnormality, but that's really from the days of plain films and CT. Now with MR, we pick up more and more subtle abnormalities, but there still are some patients, say somebody who goes up for a basketball rebound, slams to the floor, all of a sudden they can't stand up, and then a few minutes later in the locker room, sensation comes back to their legs. They call those stingers in the athletic world. It's nothing other than a spinal concussion, just like we get brain concussions, and we might see nothing on the MR scan. Of course, more severe injuries, you'll start to see edema, and the worst thing to see is blood, and blood in the cord has a very bad prognosis, so you always want to get GRE scans on spinal trauma cases to look for any evidence of blood. Another thing is disc problems associated with trauma. This is a patient who had a jumped facet. It was apparent from the CTs and the plain films they could have gone to the operating room and just reduced it with big tongs on the head and sort of rotated things, but they wanted an MR because one of the fears is, and here you can see the rotation of the jumped facet, what if you have a little piece of disc here? Here's a piece of extruded disc that's migrated superiorly, and there you see the disc. So if you did a closed reduction, you would, like a hammer that piece of disc into the cord, and there's history of patients who have closed reductions and then paralysis, and it's because of problems like this. So you do want to get MRs on these patients before the reductions. In this case, they did an open reduction where they removed the disc and put in a plate, and they didn't get an injury. Obviously, if you have a patient come to your MR facility with a big halo on, make sure that thing is MR compatible before you let them in the room, but it can be very useful. Epidural hematomas are more common actually than subdural hematomas because the epidural space is a big potential space. This is a child, a birth-related epidural hematoma. This is an adult, a Coumadin-related epidural hematoma. If you're doing LPs and myelograms, check the INR, check about the Coumadin. This can be a disaster. And there you see the epidural blood. This was your last quiz case. This is a chronic contusion. This patient was in a car accident several years back. There's a little bit of hemosiderin here, and the hemosiderin blooms with increasing flip angles. So that's a chronic contusion. Just like you get those little chronic contusions in the brain that you look at with MPGR images. This is nerve root avulsion. You can see here how the spinal nerves on this myelogram have literally pulled off, and CSF on the myelogram is leaking out into the epidural space. And you see all these expanded epidural spaces. So this patient was not, it's like a brachial plexus injury, only more medial. So we've been through the whole talk and we're done, but I'm going to show you one last quiz case that isn't spine and see if you can figure this one out. This is a 4-month-old who came in and was hemiplegic, and the parents said that this child is not moving one side of their body. And I'd like to see if you can figure out why, because this is real life, and I want you to think about this case. Why is this child, what is the problem here? Well, obviously there's a big stroke. You can see there's a whole hemisphere that's turned CSF signal. And there's lots of causes of pediatric stroke, hypercoagulable syndromes, what have you, but any clues as, look further, anything else you see? I'm stalling a bit here. What about that? A fluid level, a hematocrit effect. Any thoughts what this could be? This is a subdural hematoma. You don't get subdural hematomas with stroke. What do you get them with? Trauma. How do you get trauma giving you a stroke? This is a strangulation injury where the carotid was compressed, so you got the stroke, and there was shaken baby here. You see the entire hemispheric stroke. So this is a case where this was discovered and reported, and if this child, now at 4 years of age, has had some recovery of function. You can see the brain, the other side looks bigger, and it's really because the skull is not growing along with the brain. But the reason I show you this case is this is 6 months old, this is 4 years old. This child came back, and I followed this child's development, and because a radiologist, a colleague of mine, spotted this early on and reported it to the authorities, an intervention was made that really mattered. And some of you may be here to pass your boards, and I hope you do, but for the rest of your life it's going to be about seeing films and making interventions that matter, and I wish you the best of luck with it.